I had oatmeal too.
Okay.
I can't stop me. I ate one.
We're live. We are live.
That.
Okay, we're live. Hold on one second, Dr. Merman. Let me close the thing that is actually and totally blocking the camera view. Right. The important part. All right, so we're going back to, just again, we're still talking about primary care. I asked, Dr. Merman to come in, even though he is not a primary care provider, but I asked to get his thoughts on this as a physician. I think we wanted to make clear, you are on the Green Mountain Care Board, but you're representing yourself. You're not representing the Green Mountain Care Board.
Yes.
Okay.
So for the record, Dave Merman, I'm a physician. I'm on the Green Mountain Care Board. I work as an emergency physician at Central Vermont Medical Center. But this is totally, and I've been invited here today to speak about primary care. And so, this is totally my views informed by my perspective and my time working in these various fields. And I did not prepare slides. I prepared some thoughts to speak with you about. And I appreciate Chair Black throwing out the caveat that I'm not a primary care provider, because I was struggling with preparing this because I have a little bit of a feeling of imposter syndrome here, that I really shouldn't be speaking too heavily about someone else's field. But I think working in emergency medicine, and now I've been in Vermont for 14 years working in emergency medicine. I've seen, I interface with patients a lot, and then we interface with the primary care system. So I think I have a perspective that I think is informed, although I think that I really appreciate, that you have some of the leaders in primary care in the state, with Faye Homan and the residency director, I think, coming up from UVM, Gordon Powers, who I worked with back when he was a resident and as an attending as well, and Alan Ramsey. So all people, I think, who have really great perspectives, much more sort of on the ground and focused than my perspective, which is on the ground, but looking at it from the outside. I also want to sort of give a little caveat that I think a lot of my thinking on primary care has been influenced heavily by people you've had speak already. So Faye Homan has been involved in the primary care advisory group for a long period of time, and I've been in a bunch of those meetings and had conversations with her. And then Lisa Rosenbaum, who does this New England Journal of Medicine essay series and podcast, I think has really done a really impressive job of coalescing a lot of the important issues around primary care and thinking about them from all these different directions, which is quite thought-provoking. And I think one of the challenges is how do we work towards fixing all those things? And I don't know, there's hopefully a lot of work in this committee to come on that.
Full disclosure, I know I had my fangirl moment the other day, but it was Dr. Merman who actually sent me an episode and said, I think you might enjoy this.
Yeah.
He was right.
Yeah. It was actually my wife that sent it to me because she works in medical informatics, and she was listening to the AI episode, and she's like, you should listen to this. So yeah. But
Credit given.
yeah. And someone else probably gave it to her, so she can come tell you that at some point.
And poor Lisa thinks that nobody's listening to her podcast.
Yeah,
It's bad.
Yeah.
We are in Vermont.
So any questions, just feel free to interrupt. I just sort of had some general thoughts that I've been thinking for a while, is that primary care, when I first came to Vermont, I was amazed at the ability of my patients to follow with primary care. It was not like where I had worked before. It was amazing what we did not admit here and could get really good follow-up care. And I think we're really successful with that, 2013, 2014, 2015. As we were coming into COVID, it started to feel like we were a little bit more at risk. And I think really in COVID, it dawned on me that we were like, we're not past the tipping point. We've tipped and are colliding down the other side. And what I mean by that is, at least in my community, there were a lot of people that retired, and various reasons. There was personal reasons, there were health reasons, there were other reasons people retired. But once you kind of get that critical mass retiring, then the rest of the primary care infrastructure gets strained. And then the turnover, it just seems like we've had turnover after turnover. And so, my experience with this is mostly through talking with patients that I'm seeing. So patients are continually frustrated because they feel like they can't make appointments. And it's really the urgent visits. They can schedule out an appointment 2 months, 3 months, 4 months, not a problem. They can have their annual follow-up for their blood pressure check scheduled. But if they have something urgently wrong, they can't get in and they call. And again, overgeneralizing, I'm sure, but this is my perspective. And I see the ones that come to me, but a lot of people say, oh, I just called them and they said, just go to the ER or urgent care or express care. And I think that patients really want that connection with the primary care provider. They're calling them because one, I think they feel like it's the right thing to do. Two, they're probably financially incentivized to through copays. But three, I think a lot of them know, at least they used to have connections, and maybe they still have connections with these individuals. And so there's trust there. I do hear stories of patients, and my personal experience too, and family, is that sometimes when we go to the primary care providers, it feels like they're burdened with all these check boxes to try to justify us being there. My dad went to his Medicare screening exam 6 years ago, and he said he's never going back because it was the most useless hour of his life. And now Medicare screening exams, I'm finding out, can be done just with a phone call, which is probably good, but it's not a primary care appointment where you're connecting with somebody, developing trust, developing a treatment plan together. And then I think people feel rushed often through these very short appointments, which I'm sure you've heard about and all have felt. One more thing that I think that I see, which I don't see it that commonly, but I don't know how much of it I'm seeing, like what the part of the iceberg is that patients come into the emergency department for a medication refill. And that refill is the reason why they need that refill is the primary care provider is trying to get them in every 3 months to have a visit to prescribe the med. And I've seen this on antidepressants and I've seen this on insulin, where they missed the appointment because they had the flu. They got scheduled out 6 weeks. Now they don't have the antidepressant prescription. So I think these all speak to some of these problems with how are we, this is the payment issue. If we're paying in a fee-for-service structure, we're incentivizing schedules to be full as far out as possible so that you have a steady revenue stream. You're scheduling people to come in at as frequent intervals as you can in order to make that revenue that you need. You don't leave places in your schedule for urgent visits because what if they don't fill? You don't make the revenue. Maybe the provider is being judged on their RVU production or basically their revenue production or the potential revenue production. So if there's no appointment, they get dinged there. So there's so much incentive to keep the schedule full. Easy way to keep a schedule full, schedule it out. So I think all of those kind of speak to some of the issues that we have with payment issues. There's one more anecdote I want to give on this of my own, which is I would say, like, I don't know, back in the good old days of 10 years ago, when I asked a patient who their primary care provider was, they could tell me who their primary care provider was. And I feel like now when I ask a patient who their primary care provider is, a huge majority, maybe not majority, a large proportion of the time they would say, I don't know, or, well, I had this person and then they retired, and then I had this person, they left, and now I had this nurse practitioner and she was great, but she left, and then I have this new person and I don't know who it is. So clearly this whole thing I think Lisa was talking about last week, which I think is really important, of having a trusted relationship with a primary care provider is really maybe that's the tip that happened, is it's much less frequent than it used to be. And for those of you who have them, and I think I've spoken with people who have strong relationships with their primary care providers, you're lucky, and hold on to it, because once you lose that, it's really hard to get that again. So that was sort of like my general thoughts on sort of some of the challenges that I see for patients in primary care. And I think those all kind of relate to this concept that have been talked about of that could be related to a payment structure fix, I think could deal with a lot of those.
Like what?
Well, I think like what,
Sorry.
I think like what Faye and,
Okay.
yeah, I think what Faye and Lisa, and others have talked about is, can you pay primary care in a way that's not based in a fee for a service, a revenue generation based upon individual transactions? Can you, sort of the direct primary care model where people are paying a subscription, can you do that outside of a cash-based world and pay a capitated payment? I think that therein lies the challenge, is how do you build the system to do that, and how do you make it happen? But I think there's a lot of people who believe and would argue, and there's been some pilots of these over the years. I talked to somebody who worked in Washington in the 90s, and Medicaid had a 3-year pilot where they were in a capitated system like this, and they felt very freed to practice primary care, have non-physician team members working in concert to deliver services for people. But yeah, I think that's generally thought of as sort of the way to do that.
And that has to be done by statute? How does that, it's a culture.
I mean, an insurance company could create a capitated payment model for
Wouldn't necessarily
people.
have to be.
But value-based care is not a new idea. When you're like, this is the challenge or the concept. I mean, maybe.
Right.
Is that value-based care?
Well, I think that's
The definition of value-based care.
yeah, I think that's something that kind of came up the other day too with who was it that was talking about this? I can't remember, someone in here, or maybe it's in the other conversations I'm having, the sort of differentiation between capitated payments are commonly part of value-based care, but in the value-based care equation, you have all these measures of which you need to, value-based care is kind of like pay for performance, and so you're trying to measure the performance. And I think that a lot of the performance measures, and I think, Tom Boris talked about this, but I think others have talked about, Lisa and Faye have talked about this, is maybe some of those performance measures we're having aren't really that valuable to what we're trying to get to. If we're trying to get, so I think of capitation and value-based care as interrelated but different. And capitation in its sort of purest form, I think, would be like a direct primary care. You're just paying cash for access, and like where value-based care is, I think is really that pay for performance. You're doing well in this metric, you get a little bit more money. You do well in this metric, you get a little bit more money.
Isn't cash for access, fee for service?
Well, so fee for service is cash for transaction, where like
you're
I'm saying in direct primary care, they're just paying it's a subscription fee as opposed to, instead of, you buy your Netflix subscription as opposed to paying, remember we used to pay per movie, like
Mail in the DVD.
on the DVD,
Yes.
Blockbuster. So it's I think of those as sort of different, capitation and value-based care is similar. There's similar elements, but different beasts. So like, yeah.
Can I sort of expand and ask a question on that?
Yeah.
And it's a question I did not ask Dr. Page this morning. So value-based care it's essentially a capitated. However, the capitated payment is based upon measures that we have that we think of as value. Like the ACO model was actually, it was set so that there was a target spend. And if you increased quality so that they did not spend as much, and we've had, I know Dr. Loeffler has actually come in here and talked about this before. Basically, like you get a return on you get to share in those savings.
Yes.
You can show savings for the system
Yeah.
as a whole. You get a share of those savings. based upon this value judgment of the care you provided with a capitated payment. So would we consider that sort of model to be something that is calculated on what the return on investment would be? Can we say that that's actually making a judgment on the return of investment?
I'm not quite sure if I can answer it exactly. I guess the way I think of that system is, I don't know, 18 years ago or something, I was working in an emergency department, and some of the primary care providers were they said they were in a capitated payment, but I think they were on the hook for the total cost of care of the patient.
Yeah.
So whenever the patient would come into the ER, we'd want to admit them, and they'd be like, no, don't admit them, because they're like going to totally blow their total cost of care contract, because, you're talking primary care visit, a couple $100 a piece, admission, $20,000, so one admission totally blows that, which seemed unfair to me. When we put it into something where like you have a whole health system, that's where you have enough distribution of all those variables, right? That like, you have a big enough pie. I think that's how I think of like the Medicare shared savings program. So within Medicare, if that health system could reduce their spending in Medicare, they could take part of that shared savings. But when I think about capitated payments for primary care, I guess what I've been thinking about is, especially for like independent primary care FQHCs they're not part of a hospital, so they can't participate in that shared savings as much, I think, is to not maybe hold them so on the hook for the total cost of care of the patient, but just encourage them to do the primary care that they've been doing. And I guess there's a little bit of a leap of faith that's going to work because the measurements get the attribution and the, whose fault is it that their care went more expensive than it just gets so complicated.
And I think what I was thinking about and what I have been thinking about is that we keep making primary care responsible for the cost of care to the system as a whole, which I think of as, are we getting a return on our investment in primary care? But I wonder, does anyone ask what's the return of investment on CAR T cell therapy? That was a question I didn't ask Dr. Page.
I think when we
What's the ROI of CAR T?
How many patients?
And people, I did not ask the question because I felt like people would be horrified with me asking the question. But why don't we ask the question? Why is it horrifying to ask the question what the return on investment is of the most expensive care that we deliver? And yet, at the same time, we ask what the return on investment is in primary care.
I think we think of like with primary care, we always ask like, how much more money could we save? And I don't think we think of that in something like CAR T, right? We're not, CAR T isn't access to a very sophisticated treatment.
Or the trade-off of 9 years of neurosurgery training versus 3 years of primary care training. What's the return on investment of both of those?
Where do you think we're not looking at the ROI on that?
I think I'm putting the question out there, do we?
We measure everything, right? I mean, guaranteed, they're reporting to what's the NCQA?
Are we measuring the cost of systems as a whole? Are we measuring the value of I was at an NCSL thing this past year and National Council of State Legislators, NCSL conference.
They're good.
and it was on prescription drugs. And it was around the pricing and how prescription drugs are priced in the US. Now, that's a whole nother thing. But that other countries actually do calculations based upon, what is the value of this particular, they make coverage determinations. Are we going to cover this based upon doing a full analytical return on investment to, how will this increase someone's health? What is the return on that person's health being increased? Does it extend life? I mean, these are questions we never have in this country. Does it give you an extra 3 months of life? And what is the quality and what is the value of those 3 months? I mean, these are really hard questions that we completely, but it's not just prescription drugs. We do this for everything. And Leslie's point, what is the return investment on training someone for 9 years versus 3 years? And what are we getting for that additional 6 years as a society, as a whole, as a system, as a healthcare system?
But I think you answered that because you started talking
I
about.
was like, I did. I was about to say, I don't know how to answer this.
Well, why we're in the situation we are, why we have the neurosurgery versus primary care, because of trade organizations owned by private equity, perhaps, maybe not. Okay, I'm not going to worry about private equity, but the very powerful trade organizations in Congress that are running the system and investing lots of our tax dollars into training specialists. And we heard about that on Lisa's podcast. Dr. Gold, Dr. Rose.
Dr. Page talked about like the majority of their federal grants come from research.
That's right.
I'm sorry, go ahead.
I'm just thinking, we haven't mentioned governance, and I think that's, I don't know, Leslie, with your point and kind of circling back to Dr. Merman's. I think last year, was it 126 when we looked at I don't know where I'm going with that, but I think we, have limited spaces that we can regulate governance and good governance of healthcare entities. And it feels like that's where this conversation is kind of going back to.
I think it's important.
I don't know. I also think that when we're talking about primary care, there can be some pretty small practices out there that aren't dealing with these governance things that, are struggling to try to figure out how to stay financially viable in the system that we're in, that are trying to do really good work. I mean, I guess I guess my mind is still sort of thinking a little bit about the measurement thing. And I think at some point, Chair Black brought this up recently, I think, listening to one of your meetings. I don't remember if I was here or if it was one I was listening to asynchronously, that, if you think about the time frame of there was a time chart up there. And I think there was I think it was your testimony yesterday, Jessa, where you're talking about declining slightly, where we started having sort of decreasing numbers of primary care physicians in Vermont. And it was sort of that implementation of the EHR. And I've been thinking about that, which is, that's when we started really measuring all this stuff, and everybody's involved in, reporting and documenting to get, credit for the work you do. And I think when I talk with patients, and I think when I think about what I want out of primary care, it's back to where we actually, had someone who can integrate the information, who's a trusted advisor, who most of the time, hopefully in my health status, I don't need them, but at some points I do. And to have that touch point there. And I think that, I don't know, I guess I just think that sometimes we need to trust that the people who dedicate their lives to this work, I mean, primary care, medical students in medical school can look at all the different fields they're going into, and they can see the salaries, and they choose to go to primary care knowing they could make multiple times in a different field. I mean, you're not, I'm sure that they could do other fields that would pay a lot more. And some of them are the tops of their classes, right? And they choose to do this because they really care about the work that primary care is. And so I guess I know we set up these rubrics of measurements and value-based judgments, but sometimes I think if we just let the people do the job that they are dedicated and passionate about, and left higher paying careers and careers that have more clout within the house of medicine to do this work, I think that we should facilitate them to do their work and then have some measurements. I'm not saying go without measurement, but have some measurements that are easy. Easy to obtain measurements are sometimes challenging because they're not really the ones you want. But be really, really thoughtful that we're measuring things that we really want, because whatever you measure, that's what people are going to do. That's what they're going to be managed to. So we just need to be super thoughtful about that and maybe a little more hands off.
I asked 2 pediatricians yesterday if they were not being measured on did you counsel, and I'm assuming we're talking about teenagers here. If you did not have a checkbox that said that you counseled on tobacco cessation, would you stop trying to get your teenagers to quit smoking? Whatever, I mean, I obviously knew what the answer was going to be.
Right.
But it's, I can't get around this concept of these are people who have dedicated their lives, years and years of training to become doctors. And do we think they're not going to practice to the best of their ability?
And I would also expand that, I know there's been a lot of discussion about APPs, and the role of APPs in primary care is longstanding, and should be careful.
And
And
1982, I started.
and broad, right? And I think and maybe the financial argument of like people go into primary care as APPAs and NPs and APPs because the financial difference between there and neurosurgery or whatever may not be as substantial, but I also think it's hard work. And so I think there's a dedication and a passion to go into it. So I think that, it's beyond, it's the whole primary care workforce, I guess I would say. I think it's important to monitor things and to keep an eye on things and not have any measurements, but like, let's not have measurements that interfere with what we're trying to get them to do. So
who's like, go ahead, I'm sorry.
The conversation, I feel like we're talking a lot about should we or shouldn't we be measuring stuff? Is that really our decision, or is it the decision of Medicare, Medicaid, all the payers? Like, I don't feel like we get to make that decision
That's
at all.
exactly where I was going, like who's in charge?
Well, let me ask another question, and then that might inform better whether or not we have any role whatsoever in it. So we are struggling in the state, as is every state. We're not alone. It's not like, oh, what's happening to primary care in Vermont? Everywhere is struggling with primary care. So other than setting up a system where everybody just gets capitated payment, do you see any roles? Because we know that there are structural issues and we know that there are challenges that are in place that have led us where we are. Is there anything that you think that legislature or regulators or agencies, or is there anything that as a state we should be doing to try to mitigate some of the issues that we're having? And then maybe that will get more into the question of, do we even have a role in measuring? Does that?
I guess I combine the two because I think that if you all, are thinking about reforms within primary care, that in our last reform of primary care in the ACO model, we chose a model that had a lot of there's a lot of specifications to go with the model and the implementation of the model, which probably drove a lot of what we're talking about now. But if you're thinking about a way to try to deliver primary care in the sort of capitated way that's multi-payer, or maybe within the commercial sector, which is a pretty large percentage of the population, where you probably have a little bit easier time defining those measurements. I guess I would ask to think about one where you can be as you can let it be and understand it for what it is. I don't have any specific. There's a lot of ways to think about doing this, and I think the Senate was thinking about some ways. There's a lot of different ways to think about trying to do capitated payments, and there's going to probably be a lot of work to try to figure out which ones of those are viable.
How do you think about right sizing? That's the term, or reallocating the salaries that a specialist can command versus a specialist who's a primary care provider. So you have the extra 6 years, you're a neurosurgeon, you save a life. That's an expensive proposition all around. And meanwhile, you have a primary care physician who's, prevented strokes and all sorts of very expensive down the line care. Like, how do you truly value the contribution and set it so that it's a little proportional?
I wish I had that ever, because you said, how do I?
How does the system?
I think I'm not going to, I don't know is the short. I think there's competing factors that when we think about Vermont as a state, we do live in a national marketplace to a large degree. And so I think that sort of national thing tends to one, make it seem hopeless, and two, make it look like it's really hard to manage. I think that I think there's probably been some debate in this room, or maybe different views about whether or not primary care needs more money or whether primary care needs to be paid differently. I think primary care definitely, in my view, well, I'm going to say definitely, I think primary care needs a bigger allocation of the healthcare pot to support what it's doing. And I think yes. And so that it's, and that's, we have, I don't think you can, there's not really much space in our system to add additional money to what's going into healthcare. So you're probably going to do some reallocation. Is it going to be drastic? I don't think it's going to be drastic. And I think, frankly, like if you could make the primary care provider experience better, that I think people just love the work so much that, I think you'll still be able to attract a lot of people into it. Yes, but salary discrepancy is challenging. It's not, it's kind of how we value medicine in the US. And the whole RVU system and how it favors proceduralists. It's a complicated web to change.
Percentages discussed 12-15% being allocated to primary care, which, the overall system seems like a relatively small amount to accomplish a lot. But there are folks that are, at least in Vermont, they're getting to be a specialist.
Yeah.
And to have, I don't know if it's duplication that you need, but can't just have the ones, I don't quite know all the metrics of what you need to really stand up various specialties, but I'm just, yeah,
I mean, I think,
winning it.
in a healthcare system like Vermont, we're going to need specialists, and we need a good number of specialists. Those two lines, the specialists increasing, the primary care declining, seems alarming. I think I'm going to speak to the specialty world, but also probably applies to the primary care world, is what we need is to be able to have specialists and primary care providers. They're all specialists, right? Being able to do what they were trained to do, and making sure that, you know, if you've got a high dollar specialist, that they can actually do the work that value that you're attaining to them, that you're assigning to them is that you're getting the value out of the specialist that you want, I guess, in a sense. So, you know,
Where you were going a minute ago was to make it more attractive, like they already have the passion, they already want to do it. And you're saying, well, encourage it by making it better or easier. I mean, part of that I would imagine is the administrative burden to be able to counsel on nicotine cessation or whatever, but also get compensated for providing the good advice. And like we were hearing testimony yesterday, I can't check that box. I'm doing the work, but I can't check that box. So, yeah. Administrative burden not really felt by specialists, but I don't really know how you make it.
I know there was an interesting article that came out recently, and I can't remember the entire details, but there was a new code that was brought out by CMS to try to basically give primary care providers an extra bump in their reimbursements to do counseling and stuff. And it turns out in the implementation of the code that it's actually most heavily used by some specialists. I think Durham was called out in the paper as one of the specialties was able to operationalize this code. And part of it, so the paper summary was something about like how the specialist practice just have so much more like bandwidth to figure out how to implement a new code than a primary care practice does.
The private equity.
You know? Yeah.
There is a new code. There's a new HCPCS code.
Yeah, you probably-
Primary care can put on to basically sort of be compensated for managing the whole person as opposed to the discrete diagnoses of that one visit, because they got to think about 40 other diagnosis codes when they're thinking about this one thing.
Got my toenails.
But I think what you're talking about is that a few years ago, they redid the RVUs around E&M code.
That's right.
Which are sort of, they call them the bread and butter, they're office visit codes, they're the bread and butter of primary care. And they revalued them, and it turned out that like 10 specialties ended up uptick on those more than primary care, because they did studies where it was primary care was so busy just trying to deliver primary care that they couldn't think about upcoding.
Yeah.
And it was dermatology who like reached the rewards of it. Thank you.
Thank you.
That was the rock episode, by the way, my personal favorite episode. Thanks for coming in. Really
Thanks for having me.
appreciate it.
Yeah.
We can call off